Okay. If no, there are no more questions, we can go with Professor Salman Sharif. He will talk about acute pain, back pain, conservative management. Please, Salman.
I think, I'm going to be talking about the conservative treatment. This is again from our consensus statements that we have recently published. So you look at, I'll get on straight to it. First of all, I'd really like to thank Enrique, Mehmet, Abuzer for doing a great job, helping the WFNS Education Committee and the Young Neurosurgeons Forum to get on to a very good start. And I'm delighted, like Mehmet is on to his full speed, which is great. Enrique, a dear friend for a long time, as always, has supported us, and it's brilliant to have him here. So let me just get on to what we looked at. So role of medical treatment. So we put in this in the Google Scholar. We had these kind of studies. We looked at PubMed, and we had this kind of results out of it. There were 61 randomized controlled trials during the last 10 years that we looked at. This is from 2012 to 22. And if we look at the Google Scholar 1140, PubMed 314, eventually when we deleted all the ones which were not proper trials, then we had like 45 randomized controlled trials, 34 prospective studies. And these were the ones that we really went on to study. Which analgesic drug should be advised, indication and effects. So these were the results that we got. When to prescribe opioid, and these are the results that we had. In last 10 years, you can see very little evidence that's out there. We are not doing enough studies on medical treatment at all. Is there a role of a mild relaxant? If you look at this, only 3 RCTs, 1 prospective study, and 2 systemic reviews. So like we know that 90% of all patients with lower back pain have non-specific low back pain, as Artem has just said. And, it's the main cause of disability worldwide. Acute back pain could be defined as pain which is less than 3 months, but some people talk about 4 weeks and have subacute in between. Paracetamol. What was the evidence that it works? So according to the NICE guidelines, paracetamol alone should not be used alone for managing low back pain, but rather in conjunction with a weak opioids. But this was from 8 years ago. And paracetamol, on another study, which showed the paracetamol is regular or needed doses did not affect recovery time in patients suffering from acute back pain. So we are talking about specifically acute back pain. We are not talking about chronic pain. We are not talking about mild pain. We are talking about acute back pain. So in these patients, we have this issue. So Shahid looked at in 2021, 36 previous systemic reviews, and they concluded there is strong evidence to suggest that paracetamol offers no benefit for treatment of acute low back pain. What about NSAIDs? So it's used for various purposes. We see that not known to alter the course of a disease process. It's widely used for pain control. What about Cochrane review in 2008? At that time, they statistically significantly showed that it favors NSAIDs usage compared to placebo, but the cost of statistically significant side effects is there with NSAIDs. So you need to know your patient in order to prescribe NSAIDs. And there's another study saying that paracetamol could have fewer side effects and could be used in these situations. So the whole issue is that the recommendation then is that NSAIDs are excellent to be used, but the COX-2 inhibitor could be better because they're selective and have significantly fewer side effects of kidney or tummy. What about opioids? We have recently had this study out, and I'm going to show that as well. So Tramol, maximum dose 300, current NICE guidelines say no evidence in the use of opioids in acute sciatica or acute chronic lower back pain, because it's a dependence formation medication. Only consider if NSAIDs is contraindicated or not well tolerated or ineffective. It must be regulated. So a short course could be given of opioids, otherwise not. So no benefit over conservative treatment for acute back pain and NSAIDs for radiculopathy. So it is indeed, we say that because of opioids, the dependence could be there. So you could use in selective cases and not in all cases. What about pregabalin? Where pregabalin is excellent for sciatica, but is it excellent for chronic back pain alone without sciatica? No, it is not, and there is no evidence that it does work. It does have significant side effects, so you should know that 10% of patients would stop their medicine because of their side effects. And we should be aware of that. So these are the questions that we asked, and the answer is pregabalin is not recommended for managing acute low back pain or chronic low back pain alone. Although pregabalin has mixed results in acute sciatica radiculopathy, it has shown beneficial effects in neuropathic leg pain. It can show mixed results for chronic sciatica and radiculopathy. So yes, you could use that in chronic sciatica. What about muscle relaxants? Well, we have got broad classes are non-benzodiazepine, antispasmodics, or benzodiazepines. Currently, the third most commonly prescribed medicine for back pain. Guidelines today, US guidelines recommend as drug of choice for lower back pain. Belgian guidelines discourage uses. UK guidelines have no recommendation on muscle relaxation. Systemic review meta-analysis of 221 meta-analysis looking at this. Very low certain evidence that it might reduce pain intensity within 2 weeks of an onset, limit to no effect in 3 weeks and further. So you could use it for short duration. And there are only small trials with no conclusive evidence. So benzodiazepine, patients with acute, non-traumatic, non-radicular low back pain, no added improvement in function or pain when diazepam is added in these patients when we are treating them for back pain. Muscle relaxant, non-benzodiazepine be recommended in management of acute low back pain. Well, although the evidence is inconclusive, but non-benzodiazepine medicine may be recommended for spasm with acute low back pain. There is mixed evidence that benzodiazepine as muscle relaxant works for acute low back pain. It may be selectively used to reduce severe spasm and pain. So in selective patients, you could use it, and that too for short time, not for long term. What about role of physical medicine and rehabilitation? So these are the things we looked at in our consensus. So does bed rest mean the best conservative treatment? Back pain, acute non-chronic management, bed rest. So we looked at, and we got only 5 hits in last 10 years. So very few studies and only 1 systemic review. So bed rest is commonly discouraged. Indeed, avoiding bed rest is recommended for low back pain and sciatica. Consistent evidence that advice to stay active leads to better symptomatic and functional outcome in both short and long term for patients with acute low back pain. For patients with acute low back pain, advice to rest in bed is less effective than advice to stay active is the answer. Obviously, more studies we need to do. There are only 5 studies on this. And this open multi-center randomized study about lumbar belt wearing, it could be complementary and it supports it and reduces pain and functional status in some patients in acute setting. What about, there's talk about that if you wear a belt, are you going to lose your muscle and you shouldn't be wearing it? There is inconclusive scientific evidence to suggest that orthosis results in trunk muscle weakness. There was no change in EMG parameters, no negative effect by continuous use of orthosis for 1 to 6 months. But again, the quality of evidence has always been low in these studies. What about type of certain therapy? Would that help? Effectiveness of exercise therapy for acute low back pain remains uncertain with conflicting evidence. Neither McKinsey nor Kegel or any stabilization exercise shows any difference versus if you did not exercise. So instead of exercising, if you did common sense therapy, then it may work. But at the same time, exercises does help in some group of patients. So guidelines provide inconsistent recommendation on exercise therapy. Exercise therapy is recommended for acute low back pain in 3 out of 14 guidelines, and the other 11 guidelines provided inconsistent recommendation. Recommendations are based on patient's preference, clinician's experience, cost, availability, and safety. What about TENS? Does that work? So, all these RCTs and so many participants in this study, and shows that TENS may be beneficial for pain irrespective of pain characteristic or medical diagnosis. So no matter the diagnosis, TENS may help in certain group of patients. So it should be primarily indicated according to symptoms, that is the presence of pain rather than medical diagnosis. What about heat or cold therapy? Cryotherapy and thermotherapy had an equal effect on relieving the back pain. It supports pharmacological treatment. A hot water bottle and ice packs could be used in these settings. How about acupuncture? There is significant difference in therapy effect favoring acupuncture in this particular study for pain at less than 1 month, 1 to 3 months, and 3 to 6 months, and as well as quality of life at 1 month and functionally at 1 month and 1 to 3 months. Having said that, again, the problem is that there are very limited studies which are out there. How about the role of manual therapy in massage? Based on the current evidence, it is unclear whether or not massage is more effective than inactive control for pain at short-term follow-up. After this Cochrane review, not any RCTs have been performed. Spinal manipulation does not confer a definitive benefit over standard medical therapy that is better than sham therapy and is a reasonable treatment option. For patients with acute back pain, this is more important that we are talking about. Advice of posture, staying active, reassurance, education, and self-management strategies, in addition to spinal manipulation therapy, this particular group found more effective than anything else. So what we routinely do in our clinic is what we are talking about is more beneficial for these patients. So these are the statements that we came up with. And say it's first-line drug in acute back pain, radiculopathy. COX-2 are preferred due to lower side effects. Paracetamol is recommended for acute low back pain usage in patients of advanced age, GI, cardiovascular, or renal comorbidities, either alone or in support with opioid use in selected group of patients. Opioids have limited benefit over conservative measures. For acute low back pain, it is indicated when first-line medicines, NSAIDs, are contraindicated or not tolerated. A short course of opioids may be considered in patients with intractable back pain. So that's what we do routinely anyway. Pregabalin is not recommended for managing acute low back pain without radiculopathy because it's a local pain and should not be dealt by a radiculopathic pain. Although the evidence is inconclusive, non-benzodiazepine muscle relaxants may be recommended for spasm with acute low back pain. There is mixed evidence that benzodiazepines as muscle relaxant work for acute low back pain. It may be used selectively to reduce severe spasm and pain, so we shouldn't be using it routinely. Bed rest for more than 48 hours in acute low back pain is not recommended. Staying active leads to better symptomatic and functional outcome with acute low back pain. Lumbar support belt may reduce the pain level and augment the functional status. There is no negative effect by use of lumbar support belt in means of muscle weakness and deconditioning. But it's important to know that as you age, the belt has some rods, and those rods could irritate your back and you could be more painful. So as you age, probably having a simple abdominal compression belt would be more effective and less painful compared to a lumbar support belt. Thermotherapy and cryotherapy are efficacious on relieving acute low back pain. TENS may be beneficial for reduction of acute low back pain and has no serious side effects. There is no evidence that exercise programs work in acute low back pain. So there's no study that has clearly shown that exercise is better than anything else, especially those programs that we have, McKinsey, Kegel, etc. Mixed evidence that spinal manipulative therapy may provide short-term improvement in patients with acute low back pain, comparable with other standard treatment. There is unclear evidence that massage therapy is more effective than inactive controls for pain in short term. There is moderate evidence of benefit of pain intensity with acupuncture. And that's the answer to Moody's question. And thank you very much.
Thank you, Salman, for your great revision of this problem. And as you see, we have not much to do, only with the anti-inflammatory drugs and very few therapies like acupuncture for acute pain. Okay, open for the questions. Somebody have to do a question or a commentary. No comments, no questions.
There is a question on the chat. Is long distance driving advisable in patients with acute low back pain? Mehmet, maybe you could answer that. Long distance driving. You just need to unmute, Mehmet. Yeah.
Yeah, actually, I personally, there is not much evidence about to give literature knowledge, information about that, but it's my personal suggestion to patients not to sit down longer than 45 minutes. If you sit down longer periods, then you can have more muscle related pain or because of sitting. Sitting is not good for back, especially low back.
And there's a question about metastasis. Actually, this session is not on metastasis. It's about particular acute low back pain. We are talking about degenerative. So not going to discuss that. Moody, you want to ask something, please?
Yes, I do. Thank you very much, Salman, for the comprehensive review of the literature. I often get asked by some of my patients, more enlightened patients and the more active patients, I have had acute low back pain. If I get back into my swimming routine regularly, is it going to help me go into chronic low back pain or prevent chronic low back pain? My advice has always been, yes, do get into swimming because you are buoyant, you're building those muscles with the strokes that you take, so your core structure is going to improve. But I don't know whether there have been any studies that have shown the benefit of swimming in assisting patients get out of trouble with low back low back pain. That's my question. The comment is about the driving. I usually find that those patients who are in a position to drive in a seat which is high, such as in a four-wheel drive, find it much more comfortable and get back to out of their low back pain much more easier, rather than in a situation where their hips are lower than their knees in a low car. I have found that those patients always get into trouble, particularly if they are driving long distances over rough roads. So I have been recommending that if you are going to be driving over long distances, particularly on the kind of roads that we have in sub-Saharan Africa, some are rough roads, then try to see if you can convince your employer to get you a four-wheel drive where your hip is higher than your knees and you're more comfortable driving, rather than in those small Toyotas and Vitz and Suzukis where your knees are bent and your knees are higher than your knees and higher than your hips. And I found that assists patients, but I don't know of any studies that have, again, looked at this in a scientific way. Thank you very much for the opportunity.
I think we did not look at any study on swimming. There's question about topical agents. They work very well, and there is evidence that, along with the heat pad, if you use topical agents, it does work, has a benefit. But the main issue that we were stressing on is lifestyle modification, that, change the way we sit, walk, exercise, and people who have long drives, they need to take breaks when they have to drive, but they need to exercise regularly, swim at all possible. That's what we tell all our patients routinely. Artem, sorry, wanted to say something.
Yes, Salman, we probably discussed it before, but I want to ask again. It's quite popular in European countries to use electrophoresis with papaya products, which dissolve the disc herniation and even in acute stage. What do you really think about it? Because it's still quite popular to make electrophoresis with papaya, like different conglomerates of it. What do you think?
Mehmet, you want to answer that?
No, this is your time.
It's never proven. The efficacy never proven. But probably somebody knows, because I have acute low back pain and made for myself and it works. That's strange, but I think it's not the question of papaya.
It is exactly like what I have is my scrub nurse, who Mehmet have met as well, and Artem have met, and Moody have met, wears a black thread on his tummy, and he thinks that thread is taking away all his pain. And whenever he takes it out, he gets the pain back. So I'm happy that, it does work. So if papaya works for somebody, great. We have no problem with that. We are happy.
Salman, there is a question about the opioid usage.
Yeah, the question was on metastasis, and I said we're not discussing that. Is there any other question besides that?
Would it be better option to use lower potent opioids such as codeine per oral for relieving the pain in terms of prevent the addiction of the patient?
Okay, that's what we are saying. So now in US, it's completely changed as well. I'm sure all over the world as well, that what they're saying is that please, these are dependent medicines and you should not be giving them. So if at all you need to give a small amount for a short period. So that dependence is now there because you see these chronic patients who are on opioids for 12 months, 16 months, some years. And, it's very, very sad that GP keeps on rewriting the same thing and they don't know that what's happening with the patient. And the patient actually is, instead of changing the lifestyle, that's what's required instead of going into using these medicines. So if at all possible, we need to avoid that and try to take COX-2 inhibitors if at all possible. If for whatever reason we can't, then yeah, a combination of paracetamol and opioid for short duration could be given, but local gel heat pad does wonders. So you could apply that for 6 times a day. But make sure you have that cloth in between, or the bottle is protected, or your electrical heat pad is temperature is
What about
regulated. So
lifestyle modification? Is it a part of conservative management?
that is the most important thing, as I said. Then instead of exercise physiotherapy, instead of other things, this is more important. So, posture along with your lifestyle, whatever your work is, if that means bad posture, that means sitting for long periods, bending down, not walking, not exercising. With obese patients, they need to work, change. So, in my clinic, every day I send 3 to 4 patients to obesity clinic to sort the thing out, because we really can't help them unless they really want to help themselves. And that's the way it should be. And it is very, very good to work in combination with somebody who can also guide the patients regarding stress, anxiety. So there are many factors that play a role, especially in lower middle income countries. So I think we need to look at all those factors.
What about weight loss? It must be applied.
Yeah, I just said that with obesity, it's a problem and we need to work. And that's why many of my patients, they go to obesity clinic and get the problem sorted straight away. So there are many factors that play a role.
What about using opioid transdermal patch instead of oral administration?
I'm not sure if the addiction is in that or not. I have no idea. We can do some research and look it up. I don't know is the answer.
What about water intake?
This comes in
Adequate water intake and good hydration.
This comes in lifestyle modification, because if you're taking medicines, and especially, for example, even if you're taking COX-2 inhibitors, unless you are making sure you're well hydrated, your tummy is protected. So I think you're drinking a lot of water both ways is essential. So, if you're living in a hot climate, 10 to 12 glasses of water every day is minimum. Yeah, smoking is definitely known. So there are 2 things that I again see in my clinic every day. People who smoke and don't want to give up, or people who, on top of it, have diabetes and uncontrolled. And their diabetes, what it does is that increases the pain 9-fold of your back. So if you control, if you make your diabetic patient control and make sure that their sugar is normal, not controlled, then only you can benefit them. So I push them into going into a really normal mode instead of a control mode. And with that, half the patients get better just by controlling sugar and, knocking off their smoking. So these are the measures that everybody needs to take in order to ensure that things get better. I see Atul here. Atul, you have a question.
Atul.
Can we unmute Atul? Yeah, it's okay.
Hi, how are you?
I'm very well. Salman, I have been watching and hearing your beautiful presentation. No question, our body needs to be strong. Enrique, how are you?
Hi, fine. Thank you. Good to see you here.
See, Salman, my feeling is, as you rightly said, obesity should be reduced and all. our muscles should become strong. You see, human body is a standing position, which no other animal on the planet has standing position. And all our muscles are focused on the back of the spine. So we need to strengthen our spine. We need to make our muscles strong. We need to reduce the weight on our spine. If we are obese, our muscles are overloaded, and that can create problem of degeneration and all. My feeling is God has given a beautiful body to us. We should use it. We should run. We should jump. We should dance. We should not overweight our body, overload our system, and be happy, like Enrique.
Thank you. Okay.